probably half of y'all, but for those who don't know me, I'm Megan Baxter. I'm my third year. And my case is going to be on discectomy complicated by delayed rehabilitation. I did this case on one of my patients at my last 16-week clinical in an outpatient ortho setting in Salem, Virginia. So thanks for coming, and may the 4th be with you. So the purpose for this, the purpose for this case was to discuss the clinical reasoning and intervention strategies used for treating my patient with low back pain after delayed rehab in an outpatient ortho setting. She was a 26-year-old Caucasian female. Is that really loud? It's okay. And she came to us in January of this year. She had prior therapy before, but we'll get to that. And she works as a study abroad coordinator at a local college where she does a lot of sitting in the office, and she also does traveling, so sitting in the car and on planes for long periods of time. Her past medical history includes metabolic syndrome, which is just a cluster of conditions that increases her risk of heart disease, stroke, and diabetes, so she's on medications for that. Her surgical history, which is why she's had low back pain. She had an incident back in January of 2014 that led her to have surgery in March in Paris, France. So she had a discectomy and hemilaminectomy after having a disc herniation at L5S1 to the left. So prior to surgery, she was having a lot of pain in her left low back and down her left leg. She had radiating symptoms, but then after surgery, she had no issues with the leg pain at all, just the low back. And she had the surgery in March in Paris, France. So when she went to her first bout of treatment, she came back to the US and had it in July through December. So that was like 3 or 4 months where she didn't have any therapy right after surgery. And then after that, she didn't have anything until she saw me 2.5 years later in January of this year. Her medications are listed, mainly for her metabolic syndrome, for cholesterol and high blood pressure. And also she was on birth control. She had tried a muscle relaxer before, but it made her drowsy, so she didn't try it anymore. So you're good. Keep going. Oh, it's right here. Okay. Anyway, she tried a muscle relaxer. That made her really drowsy, so she didn't want to take it anymore, but it did help. Otherwise, she wasn't taking any medications for the pain. Her past medical history, other than that, was pretty good. She was a healthy, active individual. She was very active in dancing and going to the gym, and she wanted to get back to running. Her pain, when we first saw her, was 0 out of 10, but she said her max pain could get up to a 5. It was mostly achy in her low back area, but sometimes had some sharp pains just in the center of her back, no leg pain. Her pain increased after sitting for long periods of time, which she said about 30 minutes, and she was starting to feel the pain in her back. And it was decreased by any kind of changing in position or activity, so walking or just standing up in general and moving around felt better. So I cleared her of all the red flags for low back pain because she didn't have any progressive weakness, any bowel bladder issues, no sensory deficits or anything like that. So I was able to clear her of anything abnormal other than just musculoskeletal pain. And we just, based on her pain symptoms, we decided that her main issue was just muscle activation and coordination issues due to having pain with sitting for long periods and sometimes lifting things. My CI was McKinsey certified, so we at first thought about doing repeated extension or repeated flexion, but she did a couple of those and then it didn't change any of her symptoms, so we kind of veered away from McKinsey symptoms, just to clarify that. So based on her exam findings, her posture was a little bit increased in lumbar spinal lordosis. She had an anterior pelvic tilt. Her left iliac crest was a little elevated, and she also had a mild right lateral shift at L1, L2. Based on these findings, we were going to probably mainly focus on the lateral shift first, but we'll get to that later. And then after that, we worked on other things. As we know, lateral shift before you issues of spine. Her palpation in the lumbar spine, she had some sclerosis around her surgical incision. Her incision looked good, but just deep underneath all the soft tissue under there was just very scar tissue and adhered down. So it's very limited. As well as she had some increased muscle tone on the left, her spinal muscles in her lumbar spine. The examination findings for her range of motion were normal in the hips, knees, and ankles, but her active lumbar range of motion was limited in extension pretty significantly. No pain, just limited. And side bending to the left was significantly limited, as well as a little bit to the right. Rotation and flexion was normal. Joint mobility was increased above the level of where her incision site was, so she had hypermobility at those segments. And then it was very limited at L4, S1. L4, L5, S1 is like much more, very stiff. And we also checked her thoracic spine. It was mildly decreased, but she wasn't having any symptoms above where her low back incision was. As far as her strength findings, overall it was pretty normal, but she had a little bit of weakness on the left from probably where she had the radicular symptoms prior to surgery for about 3 months before she had surgery. So she was about a 4+ on the left and then 4- on the right overall, but in general, it wasn't like progressive weakness from the neurological disorder. Her special tests were mainly normal except for the prone instability. She was positive for that, so that makes me think more for activation issues to keep that lumbar spine stable. As well as her slump test and her sterile straight leg raise on the right were positive. So she had some neural tension issues on her right lower extremity, so from her left side to her right side. Her leg length was normal, her hip flexor flexibility was normal, and her straight leg raises were overall normal, but a little bit more limited on the right. And her oswestry index, she scored a 34% impairment, so we wanted to work on that so that she didn't feel like her back pain was limiting her function. Her reflexes and dermatomes were all normal. And going back to the prone instability test, there was an article that said that it was one of the best tests to use for low back pain patients because it had good reliability. Right. So her goals, as well as what we thought we wanted to work on with her, were to get her back to running. So just a little bit back to her therapy before she came to see us. They had told her she would never be able to run again, which she was like devastated. Like she likes to run and go outdoors and be active. So we told her we would help her get back to running and just get her back to what she wanted to do, exercising, anything like that. As well as she wanted to improve her flexibility, and I think that was mainly because she was a dancer. She liked to go, not professionally, but go to classes and dance, and I think her flexibility kind of limited that, as well as exercising in the gym. So worked on that. And then her main thing was increasing her sitting and standing tolerance for work, because that was her main issue with her pain, was limiting her being able to sit in her office, and as well as traveling for long periods of time. Using the ICF model, her health condition was the surgery that she had in March of 2014. She had the discectomy and hemilaminectomy at L5-S1, and her impairments were the decreased lumbar spine, joint mobility, the range of motion, the sural and hamstring mobility, a little bit of lower extremity weakness, and pain across her low back, which was her primary impairment, was her pain that limited her from sitting for long periods of time. The activities she had difficulty with were lifting, sitting, running, exercising, and traveling. The participation activities that were a problem for her were her work duties for sitting, any kind of recreational activities like running, dancing, and exercising. The environment, she worked in the office. She would come see us in the gym, as well as go exercise in the gym all the time. The car, the plane, dance studio, and at home when she did her home exercise program. Her personal factors, she was 26, female, so she's pretty young. She's very active and motivated to get better. And that kind of helped with her prognosis, but on the downside, she's had this issue for going on 3 years now, so we also had to take that into consideration. All right. For her evaluation, I decided to classify her using the deleted classification, but my CI used the Sullivan classifications for low back pain. He said that she was primarily a mobility issue, because she was very stiff in her lumbar spine, as well as the flexibility and cervical nerve mobility deficits. And then secondary was stability, so her core exercises and lower extremity exercises would help with that. But I used Toledo, and I used the chronic low back pain with movement coordination impairments, because I think it was more of a motor control issue with her sitting for long periods of time. Her muscles probably just get fatigued and can't support her spine, and just kind of chaining on the ligaments and all that. But based on some articles I read, the prognosis I had set for 2 to 3 weeks for 8 weeks, and that's what the article said was good for acute and chronic low back pain patients. But also considering her delayed rehab, it might take longer, but I figured we'd start with this and go from there. Which she was doing really well, but we'll get to that later. But eventually we had to kind of extend it because of other circumstances. So like I said earlier, her plan of care started with correcting her lateral shift, which only took a couple of treatments for that to correct itself. As well as improve her lumbar spine mobility, increase her hamstring and cervical nerve mobility, increase her lower extremity strength, as well as like biomechanics with exercises to kind of just help her move more in a coordinated fashion. Improve her sitting tolerance and running form and endurance, because I know that she wanted to get back to that. And then improving her body mechanics with all the exercises as well as activities that she wanted to get back to, so she wouldn't have any further issues down the road. Any questions so far? Yes.
Like you said, that the repeated events were affected drive traction.
So he had a traction table. I'll repeat the question. She asked about any other traction would help other than the repeated movements. He had a traction table, but he disassembled it because he felt like it wasn't very useful, because once you stand up, gravity's going to push you back down to the press. So we didn't have that option. Honestly, it could have been used as a Band-Aid to help with the symptoms, but it's not overall going to help her long term. If she was more of a severe case, like it was really excruciating, maybe that would have looked into like reassembling it further, but her pain was like 5 out of 10. So.
What exam findings led you to conclude that she had a motor coordination deficit?
Oh, I forgot to say we did a functional squat just to see what that looked like. And it was, she was shifted to the right when she went down, and she was forward leaning with her trunk, and her knees were forward. Everything was just awful. And that looked like her lower extremity muscles were making up for her core muscles, so she wouldn't have to rely on keeping like a stable spine. She was just very abnormal.
Did you do any kind of flexion or extension endurance tests or engagement coordination tests of any sort?
I didn't, but I feel like I should have in the beginning. I should have done like a long sit test or something like that.
Or maybe not long sit.
Yeah, like a
hook on a sit.
Yeah. Yeah, I think that would have been good to feel what her endurance would back to. Yeah. Any other questions? So for her interventions, we started out with doing some education on her posture for work when she's sitting in the chair, and also when she's traveling, kind of making sure she was sitting with upright posture, not slouched over, putting a lot of stress on that lumbar spine, as well as educating her on the differences between harm versus hurt. So she was having pain because it was putting stress on things, on her soft tissue around her low back, but it wasn't harming, like it wasn't causing damage to her area. So I think a lot of it at the beginning was more psychosocial, like educating her that it's okay to move and do exercises and not hurt your back. You're not going to have another disc herniation as long as you do what we tell you. So we mainly did posture education, educated her about the pain, as well as did some joint mobs and stretches, as well as some manual treatment to help with the pain in her low back. For the next 2 weeks, we worked more on the strengthening. We did that at the beginning too, but we worked more on kind of the lower extremity strengthening, as well as endurance with increasing the reps and sets with each exercise, which she progressed really well, as well as continued mobility exercises and pain modification and manual stuff, which we'll show you exercises that we did for each of these in just a minute. And then the last 2 weeks that we worked, for the weeks 5 through 6, we did more dynamic exercises. Those included like tilt board squats and planks and more functional activities, standing rather than laying on the mat doing leg lifts and stuff like that. And we had started doing some running on the treadmill. Probably like 2 sessions of that, just assessing her form and giving her some cues on how to fix it. But then for the next couple weeks, for the next 4 weeks, she had come in complaining of some severe left neck and shoulder pain, and we focused more on that rather than her back. From what she requested, she was wanting to prefer our treatments based more on her neck. So that was more manual stuff and just pain modification stuff. A lot of stuff, tissue massage. My CI did dry needling and some joint lifts in her neck, and that seemed to help some. It got her pain down from a max of like 10 to about 6 out of 10. But then she was still having issues, so she eventually got a cortisone shot in her neck, and that relieved her symptoms completely, and she was fine after that. I'll get to it later, but I think it might have had to do more with stress from her job. She had a lot of deadlines coming up and a lot of stuff she had to do, turn in, and all that. But we'll get to that later. And then the last 2 weeks that I saw her before my internship ended, we worked more on the back stuff again, gave her some education on running mechanics and more of the dynamic exercises, and she was doing really well. And she was getting close to discharge, but then I ended my internship, so she was done with me. So these are some of the interventions that we used. The first one in the top left corner is just the lateral shift correction that she did at home and in the clinic as well. That only took like 2 treatment sessions before it was corrected. And then we worked on the seated nerve mobility with the seated nerve glides. And then some of the exercises you see to increase the lower extremity strength as well as keeping her core nice and activated during the seated trunk rotations and the planks and some of the other kettlebell, single leg deadlifts and squats. Then the next month, this is what we did for her shoulder and neck. I had the dry needling. This isn't her, but just a picture of an example of what they were doing. It's more in this area and some in the scapular region, as well as some kind of postural exercises to help with scap retraction and neck retraction to keep that forward head from going forward to help with the neck pain. And she did really well with the exercises, and from what she told me, she did her exercises at home religiously. So who knows if she really did it. And then when she came back after the neck stuff that resolved for the low back stuff, we did more for dogs and like walkouts, some ball bridges and stuff like that, as well as the running on the treadmill. And her form looked a lot better after probably 5 sessions of doing treadmill work. And then my CI was also very heavy manual treatments. He did a lot of manipulations and McKenzie stuff. So he did some lumbar spine rotation manipulations to keep that lumbar spine mobile. That was really stiff in the beginning, but it was less and less throughout the treatment sessions. She didn't need them as much. But every once in a while, she would feel like she needed a pop, and she would do that and feel good, so we would exercise after she popped. So during her running analysis, we determined like I said, that she had a lot of tension in her shoulder. She would kind of run like this, and we told her to stop doing that. That helped. She had the heel strike. She had the decreased stride length on the left lower extremity. I feel like she was just kind of favoring that right leg a little bit. And then she had a decreased step width. Her feet were really close together, so we just told her to spread them apart just a little bit so she wouldn't trip and fall. As well as she had a lot of force going through her feet, so when she did more of the forefoot running technique, it kind of helped with that as well to kind of decrease the force going up the chain into the lower extremities in the back. For her home exercise program, she did the TheraBand trunk rotations that I had a picture of, hamstring stretches, the seated nerve glides, and some lower extremity strengthening exercises, as well as the planks. But she was also doing dancing outside of her exercises in the gym, as well as trying to incorporate some running and some cardio on the treadmill at the gym and a little bit out on the roads too. So from beginning of treatment to last time I saw her, she went from 34% impairment to 18% on the ODI. She had 2 progress notes in between, but just went from beginning to end to show the total improvement. Her pain went from a 5 to a 3, but she also said that her pain was a lot less frequently than before. And her strength went from a 4 minus to a 4 plus, and her lumbar spine extension improved significantly from like 25% normal to 75% normal. And her sitting tolerance, she said she could sit about 2 hours before she started having pain. So that was a lot better. She had no neural tension as well. At the beginning, she had, I think it was like 40% with the straight leg raise. She had no issues at the end. She had improved running form, and she had a significantly decreased frequency of pain and longer duration before she had symptoms. So functionally, she was doing a lot better. Limitations for the clinic, or I'll start with her. She had a busy work schedule and she was traveling a lot. So sometimes she couldn't come see us every week, and she would be off wherever she was going and couldn't get in but maybe once that week. So that's one limitation. She couldn't see us every week for 2 or 3 times. That's why we had to see her for a little bit longer than 8 weeks. Plus she had the neck issue. So that was a month of treatment. For the clinic, we had a lot of patients at one time. I think the max that I saw was probably like 24 patients in a day, and we'd see them for about an hour each visit. So it's kind of hard sometimes to get one-on-one treatment with her, but most of the time, I mean, my CI would help, and we had techs, and they would help with their exercises after we kind of did the manual treatment. So that did help some, but most of the time it was very hectic, and it's a small gym, and just kind of hard sometimes to kind of make sure she was doing what she was supposed to be doing with the right body mechanics. Another limitation with the intra-rater reliability, that's always an issue with the progress notes, and from doing eval to discharge, there could be some leeway on how I did the techniques from one progress note to a discharge. She also had an orange flag of depression, which I wish I would have addressed more at the beginning, because she wrote it on her form, but when I was doing the eval, she was very happy-go-lucky. Didn't seem like she was depressed at all, so I didn't even mention it, but I feel like I should have at least addressed it sometime within the course of treatment that I saw her. And also she had to leave rehab, and I think that kind of maybe caused her to take more time with me to get better than maybe somebody that saw me right after surgery. So what I would do differently, I would probably ask more questions in the eval about the depression, as well as maybe more information about fear avoidance, since she had some probably psychological stuff going from when they could. She said that they told her she couldn't run anymore, and just stuff like that. I feel like maybe some of that psychological stuff might have still been hindering her from getting completely back to normal. As well, she told me she had intentionally lost some weight after surgery, but I don't remember how much, and I didn't ask her if that affected her symptoms at all, and I wish I would have. And I think that's due to her like metabolic syndrome. It's healthier if you lose lose a little weight. She was a little overweight when she had the injury. As well as I wish she could have probably done exercises with more intensity faster. She could have handled it more quickly than some of my other patients that were kind of older adults, have more complicated medical histories and stuff like that. Kind of just wish I had progressed her quicker than I did, but overall, what do y'all think I should have done differently? Any ideas? What would you do? No? Okay. Here's my references. And thank you. Questions?
Physical therapy services after one bout of therapy where she wasn't happy.
Why did she come see us? Because she was still having symptoms. She was still having pain and issues at work. I think she probably waited so long because she was unsatisfied with PT that she had had before. But she still thought PT would help. So I think she tried to wait and see what she could do at home probably and see if the symptoms got better. But I think they were still bothering her at work so much where she could only sit for 30 minutes without pain. That she could see somebody.
Obviously had a big impact on this patient. She's back to running and she was told that she would never run, so
It's just crazy to me.
nice job. I want you to think about something though, if, in some respects, I know I'm making a generalization here, but you sort of had the shotgun approach here. You did some mobilization, you did some stabilization, some lots of things. But that's not appropriate, I think oftentimes it is. But if you were to have to decide what was the most important thing, or if you could only do one of those things, what do you think would have been the most important thing to do for her, and why do you think that?
I think just getting her to move more. Like I think she was being cautious because she thought she would hurt herself, and just educating her that she wouldn't hurt herself. She was getting back to what she was doing before. I think movement in general would be best. I think it was more psychological, which I wish I would have addressed more.
We didn't really address it very much with your class to the extent that we are now, but refer you to David Butler and former Mosley's work, which I'm sure you see on talking about some too. That what you're talking about is that big impact.
And I know some of my classmates had talks with their patients about maybe for our book that they were talking about. I wish we had something like that. Or they aren't clinical. But yeah, maybe we'll find out. Any other questions?